Yeah, I think that you can do like something about cardiovascular disease.
Your research interest.
Interesting.
Hello. 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 Good afternoon to all our audience, and good afternoon to our in-person audience as well. Good afternoon to AstraZeneca, our able sponsors. Good afternoon to all the team here. I'm Dr. George Bidiagun Ketia, software president. I'll be moderating this section of the CPD. Over the last month, we've been celebrating the World Family Doctor Month, where we had a number of CPD programs. The aim is to make sure that our primary care physicians are well equipped to be able to take care of our clients at the primary care level. So we've had our first CPD was on asthma, the current trends in the management of asthma. We've had current trends in the management of hypertension, preventing CVDs and CKDs. And today, we are going to have a very interesting topic. Title of our CPD today is Dealing with Chronic Kidney Disease, Current Trends in Management. Dealing with chronic kidney disease, current trends in management. You all would agree with me that currently we are having an upsurge in the number of CKDs that we are having at our clinics. The prevalence is really increasing, and it's high time that we talk about it and deal with it. And I always believe that if it's not taken care of at the primary care level, by the time it gets to the tertiary level, either they cannot afford or they cannot even access the care. Today with me in the studio, we have able speakers who will be taking us through the various topics. Before I start, I just want to call on Dr. Anita Thibault to pray with us.
Shall we pray? Our Lord and Master Jesus, we thank you and bless you for this afternoon. We thank you for the chance to gather to study. We ask that your grace shall be with us. Grant us wisdom, grant us understanding, that whatever we learn, we'll be able to apply it to take better care of our clients. In Jesus' mighty name, amen.
Amen. Thank you very much. We are streaming live on Zoom and YouTube. Kindly tell a friend that if they are not able to get into the Zoom meeting, they can join us via the YouTube. Because currently we are 480. So it means that we can admit just about 20 more, but just know that the YouTube is open and you can join via the YouTube. I've had a lot of complaints that sometimes you are on and somebody kicks you out. I mean, it's a world of struggle. So when there's space, there's a lot of struggle, but we've made avenue for everybody to be able to join in. So in case somebody kicks you out, kindly you can join through the YouTube. Thank you very much. So we'll zoom right in with our first presentation. Our first presentation will be taken by Dr. Baba Damoa. So, but Dr. Baba Damoa is a fellow of the Ghana College of Physicians and Surgeons. She's a senior specialist with the Kolebu Teaching Hostel, currently the clinical care coordinator of the Family Medicine Department. She has a lot of interest in cardiovascular disease and prevention and health promotion. She's currently running a project in POCOs in emergency obstetrics in the Savannah and Western region. Ladies and gentlemen, kindly help me invite Dr. Baba Damoa as she takes us on the topic, prevention and early detection of chronic diseases. Dr. Baba, please take.
Hello, good afternoon, everybody, and thank you very much, our able President, Dr. Nketia, for this opportunity. Can I be heard? Okay, so this afternoon, I'll be leading the discussion on chronic kidney disease. Specifically, I'll be touching on the prevention and early detection of chronic kidney diseases. And I'm hoping that our empower primary care physicians across the platform listening to be able to identify and also to intervene as early as possible. I'm Baba Damwa, and I'm a strong member of SOFPO. So by way of learning objectives, I'm hoping that after our discussion, the global and local epidemiology of chronic kidney disease will be established. I'll be able to identify some key risk factors and causes of CKD. We would be able to recognize the importance of early detection and screening. We'll be able to also understand and discuss some prevention strategies, especially in primary care. And then we'll touch on some emerging technologies in CKD diagnosis. By way of definition, CKD is defined as any abnormality of the kidney structure or function, or an estimated glomerular filtration rate of less than 60 ml per meter per 1.73 meters squared, persisting for 3 months or more with health implication. This definition actually spans through 2 areas. One is talking about the kidney structure. So you can have a problem with the kidney structure going on for 3 months or more, or the kidney function. You can have one or the other, and it's important that we consider this in our definition of CKD. Early recognition of CKD is actually the first step in treating it. You can't treat what you don't know. And it's important that we know that management of CKD involves adjusting medication dosages. We may have to also prepare our patients for renal replacement therapies and also address reversible causes to slow down the disease process as we see them in primary care. As far back in 2012, the Kidney Disease Improving Global Outcomes came together to classify CKD based on the cause, the eGFR, and the level of albumin in the urine. Using the eGFR, it classified the stages into 6, what we commonly would call stage 1 to 5, with stage 3 split into 2, 3A and 3B. Most importantly, this heat map they drew gives us an idea that when we classify our patients with CKD, we should be able to know that these ones have mild diseases, which is indicated by the color code green, and progress to its worst form, where it's indicated by deep maroon color. This heat map also shows us, on the average, the number of times in a year we need to see these patients. For instance, if the patient has mild chronic kidney disease, you may see them once in a year, or when they develop to moderate, you may see them twice in a year. But when they have severe disease, we may be seeing them more than 4 times even in a year. This heat map also makes us understand that we cannot diagnose patients with CKD by just considering eGFR levels. It is important that we have this combined effect of their urine protein levels, their EGFR levels, and also the cause of what is precipitating their CKD. So by combining this, we can be able to say that, okay, this patient has a mild disease or moderate disease and can be seen in primary care. Or no, let's refer to our able nephrologist to coordinate their care to make sure that they receive the best of care. Globally, the prevalence of chronic kidney disease spans between 11.7 to 15.1%, with an average of 13.4%. This indices actually shows that the prevalence is much higher in low and middle income countries, which Ghana is part of, where in Africa, the prevalence actually goes higher to 15.8%. In sub-Saharan Africa, the prevalence is noted in literature at 13.9%, and specifically in Ghana, 13.3%. But I must say that Tano et al. In 2023 said that, as I indicated earlier on the heat map, most cases of CKDs are undiagnosed because they will not have structures. They may have structural problems, but may have normal EGFR or may not have any proteins in their urine. So it's believed that a number of our patients with CKDs are actually not diagnosed, and that the prevalence may actually be higher than indicated on this slide. So the National Kidney Foundation in 2024 brought up some facts, which I thought should share with everybody to know. That in the United States of America, which is a high-income country, 1 in 7 individuals have CKD. And then when you consider 3 people with diabetes, at least one of them will have chronic kidney disease. And 1 in 5 adults also have, with hypertension, also have CKD. This shows the enormous problem of CKD we have on our hands. Apologies, but this pie chart is not very clear, but the dark blue side represents patients with diabetes with CKD, showing its major influence on the diagnosis of CKD. This is the portion representing patients with hypertension with chronic kidney disease. And this is patients with glomerulonephritis having chronic kidney disease. And when you come down to Ghana, the picture is not different. Most of the patients who have diabetes, hypertension, and glomerulonephritis precipitating their or causing their chronic kidney disease. It's also important for us to know that as Blacks or African with Black or African lineage, our incidence of getting CKD and actually end-stage renal disease can increase as high as 4 times compared to that of the white population. We'll move on to the risk factors. And risk factors for chronic kidney disease can be broken down into non-modifiable risk factors and then risk factors, modifiable risk factors, which are in green. Increasing age above 60 years is associated with a higher incidence of chronic CKD along with gender. Males have been noted to have more CKD, and really so because they also have a high incidence of cardiovascular disease. For ethnicity, I had already described how Black or African descent individuals are more susceptible to chronic kidney disease. There may be some genetic components like autosomal dominant disorders like polycystic kidney disease, where patients will have CKD through no acquired cause or risk factor for them. And studies have also shown that low birth weight also increases your risk of getting CKD. These are things we can't do much about. But when it comes to the modifiable risk factors, the big one is still diabetes. I put it in red. Most of the patients we see in our OPD with diabetes and hypertension, if we recognize that a big chunk of them have an increased risk of developing chronic kidney disease, it will solve our problem. Another big one will be drug toxicity. In Ghana, it's quite easy to walk into our community pharmacies and get easy access to NSAIDs or some antibiotics, and we take it as often as we can when we know very well that they have not been prescribed by our practitioners. The essence of this is that at the long run, it predisposes the patient to CKD. Subsequently, other things like autoimmune diseases, SLE, rheumatoid arthritis, recurrent urine tract infection, especially in patients with lower urinary tract obstruction, have all been shown to increase the prevalence of CKD. Other things we may want to consider as we see our patients in our clinic would be obesity, dyslipidemia, hyperuricemia. These all go to increase the risk factor for CKD. And we must know this so that we know what to institute for these patients. So when we come to the causes, now that we know the risk factors, and I must say the risk factors and the causes often overlap. The causes of the CKD can be divided into three main areas where we can consider pre-renal causes, intrinsic renal causes, which is the big one really and form the chunk of the problem, and then post-renal causes. For pre-renal causes, you may have issues, conditions like congestive heart disease or chronic liver failure, which actually leads to poor perfusion to our kidneys and subsequently predisposed to kidney disease. And then for post-renal, when you have obstructive uropathy from enlarged prostate gland or from pelvic tumors, from urolithasis, which lead to a backlog of urine and subsequently kidney failure, it actually increases our risk of getting CKD. The big one is the intrinsic factors. And once again, it still comes down to diabetes, hypertension, glomerulonephritis, and other things. These diseases affect the intrinsic renal vascular system, the glomeruli, the tubulointestinum, the blood vessels, and the parenchyma of the kidney tissue itself. And it leads to it's being abnormal in function or structure. And when it prolongs after 3 months, we say that the patients have CKD. So in our primary care, when we have patients with these increased risk factors or not, and they are sitting in our consulting rooms and want to find out what are some of the symptoms and signs that they may present with, I want us to think about, know that majority, almost a lot of patients will be asymptomatic. So if you look at my list, I decided to repeat it 3 times because it's very important that as you are looking for the symptom and you are not finding anything, you remember that it is asymptomatic. And even when you are still trying to find symptoms of CKD, especially in the early stages, remember it is asymptomatic and will not have any symptom at all unless you screen these patients. However, other symptoms like nausea, vomiting, loss of appetite, patient feeling weak, patient having sleep disturbances, oliguria or anuria, patient not producing enough urine. The patient may have mental sharpness decrease, all the way down to even being comatose as a symptom of CKD. The patient may also present with muscle cramps, pedal edema, persistent pruritus. They may present with chest pain when it's not necessarily an MI or a pneumonia due to uremic pericarditis. The patients may present with dyspnea when they have pulmonary edema, or they may present with uncontrolled BPs when they have CKDs. For signs, we can look on the skin for hyperpigmentation. They may have scratch marks from excessive pruritus and scratching them. When we listen to their chest, we may hear a pericardial rub from uremic pericarditis. And the hyperuricemia may result in uric acid being deposited on their skin. It forms a white powder known as uremic frost. The patients may also have hyperreflexia. When you look in the eyes, they may have fundal changes suggestive of severe hypertension, such as cortical spots, retinal hemorrhages, and so on. So who do we screen for chronic kidney disease? Current evidence suggests that there is no evidence in screening the general population for chronic kidney disease. However, individuals with risk factors, which we have already discussed, need to undergo some sort of screening for you to be able to pick the CKD earlier on. And some of the things you can do will be blood tests, the serum creatinine level or EGFR, which you can use the CKD epidemiology collaboration equation or the modification of diet in renal disease equation. The MDRD is actually very useful in estimating the glomerular filtrating rate. You can also do urine analysis. You can do measurement of the urine albumin creatinine ratio in order to help to ascertain the class of the CKD or to screen them. It's important that high-risk patients with obesity, diabetes, hypertension, we screen them annually. So when we have patients sitting in front of us and after 1 year, we don't have any labs to screen of their kidney function, we know that we are not doing the best for them. They should at least have an annual screening done. Patients should be tested on 3 separate occasions over 3 months, and 2 out of these tests must be positive for us to diagnose CKD. For imaging, the cost-effective one we can do will be an abdominal ultrasound, where we recognize small kidneys, reduce cortical thickness, and the kidneys will have a high echogenicity. There may be scarring. If the patient have a polycystic kidney disease, we may see multiple cysts. This is cost-effective, and it will go to confirm that the patients may have a chronic kidney disease. Aside this, we can have a CT done, renal angiography, radionuclide renal scans can also be done. The new one, in addition, is an AI-based prediction models for early kidney detection, where AI softwares have been integrated into these imaging technologies, and they are able to predict or detect CKD way earlier than if these imaging modalities were used alone. A paper published recently in 2025 spoke about this. And I thought I'd bring it up now that artificial intelligence is really in every part of our world. In considering the natural history and progression of chronic kidney disease, I want us to think about it in 2 ways. The patients that sit in front of us usually will have what we call community CKD or referred CKD. For patients with community CKD, these are the older population. They would have had hypertension, diabetes, obesity, or all the risk factors for a long time, maybe during their middle years up to old years, and they may have been on some sort of treatment. Their EGFR decline usually is low and below 1 ml per minute per year after 40 to 50 years. These patients really can be managed in primary care if you continually do your screening and intervention, and they may go and die from other causes, not necessarily CKD. On the other hand, maybe the patients classified as referred CKD. These come in as young adults. They may still have hypertension, diabetes, but they have a more fulminant form. Their BPs are not controlled. If it's diabetes, they have type 1 diabetes, sugars are in the roof. These patients may have sickle cell disease. They need, and the rate of decline of their renal function is usually very rapid. For instance, patients with diabetic nephropathy can lose 10 ml per minute per year function of their glomerular filtration rate if they are not seen adequately and then managed. So it's important that we recognize these 2 different groups and know that especially with a referred CKD, we will need to coordinate care with a nephrologist. as soon and as quickly as possible so that these patients can receive optimal care. So having discussed all these factors, why are we worried? I believe at the end of this discussion or presentation, these prevention strategies should be on all our minds. As primary caregivers, our first thing is to prevent the disease. And then when we get it, to manage it as quickly as we can. So for prevention strategies for chronic kidney disease, we may want to look at lifestyle modification, healthy diets, which includes eating fruits and vegetables, unrefined carbohydrates, lean protein, reducing saturated and trans fats, eating more monounsaturated and polyunsaturated fat may be a good way to go when we counsel our patients and even ourselves. It is also essential that we exercise every day as much as we can. But if that is not possible, we can do moderate intensity exercise of 150 minutes in a week, or high intensity exercise of 45 minutes in a week. Making sure to combine both aerobic exercises, muscle straining exercises, and all that. It is important that we reduce obesity. We speak to our patients to stop smoking and reduce alcohol or stop if they can, because all this go to increase their risk of getting chronic kidney disease. For the modifiable risk factors we discussed earlier, we should be able to treat our patients to their targets. There are guidelines available, and based on particular doing patient-centered care, we'll be able to treat our patients to the recommended target for the disease process they have. It is not enough to be coming to the hospital with hypertension and be on antihypertensive medication when your BPs are still above 140, 90 millimeters mercury. You are not within target. And that means that the disease process is still going on, and the CKD, they still have an increased risk with CKD. Similarly, the same thing goes with our patients with diabetes. So let's see them and manage them and treat them to target goals, whilst we are also rendering patient-centered care for them. Especially in Ghana, where in primary care, diabetes and hypertension make up over 90% of the non-communicable diseases we see at our OPD. Managing these risk factors alone may go a long way to help with controlling and preventing chronic kidney disease. Finally, I would like to touch on educating our patients to understand what it means to have a regular follow-up. Most patients may be diagnosed with this condition and may not understand that it's a lifelong condition to have hypertension, diabetes, that they need to be on follow-up for a long time. They go and their medication run out and they feel they are fine. Or they go and when their pressures normalize, they feel they are fine, they don't come back for follow-up. Then their pressures will shoot up again, and then the risk factors are all back to normal. It's important that we speak to them and give them this counseling as we see them. Secondly, medication adherence is the big one. Taking medication every day for the rest of your life may not be easy for our patients, but that may be what we need to do to continuously support them and help them to adhere to the medication. Finally, we can also educate them on safe medicine practice. Unfortunately, they may be able to get some medication without prescription, but if you let them know that it's important that whatever they take is based on prescription, it will help them to adhere to this and prevent their risk of getting CKD. Why is it important to even prevent this? Because CKD really has an enormous effect on us. It affects the carers. You have a caregiver who have to always be there to take the patient to hospital. If the patient have an end-stage renal disease, They have to accompany the patient for dialysis and all that. And it puts a lot of pressure on these carers. It affects work and productivity. Most patients with chronic kidney disease, especially severe and moderate to severe forms, will be too weak to go to work. They are fatigued and tired most of the time. It has a bidirectional effect on hypertension, cardiovascular disease, and diabetes, meaning that CKD worsens these conditions, and these conditions in effect also will worsen the chronic kidney disease. It's significantly reduced the quality of life. I cannot overemphasize the morbidity and mortality that is associated with chronic kidney disease. And at the end of the day, it also affects cost. Before the National Health Insurance Authority rolled out the free dialysis program in December last year in Ghana, the cost of dialysis in our public sector hospitals range between 300 and 800 Ghana cedis per session. Now, if you had to do 3, and the cost for doing this dialysis in a private facility range between 1,000 to 2,000 Ghana cedis per session. So taking an average of 1,000 cedis, if you had to do 3 sessions of dialysis for end-stage renal disease, you are accruing 3,000 Ghana cedis a week. In a month, you are paying 12,000 Ghana cedis. In a year, you are paying 144,000 Ghana cedis. How many Ghanaians can afford this? It is on this note that Dr. Asiedu Sapon said on Joy FM that over 90% of Ghanaians can't bear the cost of dialysis treatment in the country. So it's a good thing that the National Health Insurance has rolled out this free dialysis program. But still think about it as prescribers and physicians. If we can adequately prevent this disease, then this amount of money that the National Health Insurance Authority is going to pump into treating this condition can be diverted elsewhere when patients are not overburdened with chronic kidney disease. Perhaps it is something we can all think about, as my colleague, Dr. also coming later on to talk about the management of CKD. So in effect, as primary care physicians everywhere, especially in a locally undersourced country like Ghana, it is important that we note the early prevention and early identification of chronic kidney disease. Know that most patients will be asymptomatic, so we need to actively screen high-risk people, which I'm sure by now you can confidently identify them. Then when you screen them and categorize them according to the heat map, you should be able to develop interventions or monitor progression over a period of time till they get to moderately severe disease, usually stage 3, where you want to quickly coordinate the care with a nephrologist. Coordinated care with a nephrologist doesn't mean you have referred to a nephrologist and you don't see again. So they go to a nephrologist, you discuss how the patient can have the patient-centered care, and together you magnify the management for these patients. So I want to conclude by saying that chronic kidney disease is a significant health issue, especially in Ghana, and that early detection and intervention significantly slows the progression and will dramatically reduce the prevalence we have in this country. And as primary caregivers, we are placed in a key position to be able to drive the prevention and management of the early stages of this CKD, whilst we coordinate the care with the nephrologist at the later stages. And it is good to know that technology is now being used to enhance the diagnostic potential of chronic kidney disease. These are my references, and thank you very much.
Thank you very much, Dr. Baba Damoa. I think that we've learned a lot from it, from the primary care level. The first question is that when you see a high-risk patient, will you identify them? 2, are you dealing with the high risk or the risk factors in this client? Are you screening to even know whether they have the disease? As she said, the early stages are asymptomatic. If you are waiting for them to come and give you complaints, our nephrologists will always complain. Let's say again that if you are waiting for them to complain, you are going to let an nephrologist always complain because they cannot take care of the number of cases that are getting to them. If you're able to pick them early, then of course we can manage them and prevent the progression so that they don't get to end stage where the care become costly and access to even the nephrologist. I mean, I was attempting to count the number of nephrologists that we have in Ghana, and within a few minutes, I was able to count them all. A number of regions do not have any. And if you're like me, who is a primary physician, and trying to work with the primary care facilities, and if you know the distance between probably the district hospitals and a lot of the health centers, then of course, we will always pray and work hard to make sure that our clients are not getting to that stage. Because even getting the district hospital is a difficulty, more or less to the regional hospital, where they might not even find a nephrologist, and to come to the teaching hospitals, it becomes a problem. Prevention, prevention, prevention. Thank you very much, Dr. Baba Damois. I mean, we've learned a lot from this. Next on our bill, we're going to have one of our very own. For me, I call all of them our very own because now every physician is a primary physician because we are all tackling it from the beginning. So we're going to have Dr. Akosia Asumeni. She is a nephrologist and a physician specialist at the renal unit, Department of Medicine and Therapeutics, Kolebu Teaching Hospital. You know, when you mention, as I said, there are few. So either you say Kolebu Teaching Hospital, Convanoti Teaching Hospital, or you will say Cape Coast. I mean, there are few. So always when you are mentioning where they, I realize that teaching hospital may follow. So we need to make sure that we are preventing it because our clients may not. She's a fellow of the International Society of Nephrology. She has fellowship in artificial fellowship certificate in nephrology from South African College of Physicians. I was actually going to say that she has a certificate in AI in detecting kidney diseases, but she said she's not gotten that one yet. Ladies and gentlemen, help me invite Dr. Akosia Asumeni as she takes us through current trends in the management of CKD from the family physician to the nephrologist. Thank you.
Okay. Good afternoon, everybody. I would like to say a big thank you to the president and the executives of the Society of Family Physicians of Ghana for inviting me to talk about chronic kidney disease, current trend in the management from family physician to nephrologist. Dr. Damois has given us a very great outline and there are quite a number of things I would highlight which she has already spoken about and would go into the management of chronic kidney disease and a few current trends available. So this, as a form of a disclaimer, this presentation is intended for educational purposes only, and it does not replace any independent professional judgments. The statements of fact and opinions expressed are those of myself, and unless expressly stated to the contrary, not the opinions or positions of AstraZeneca. And AstraZeneca does not endorse or approve and assume no responsibility for the content, accuracy, or completeness of the information being presented. For my disclosure, it's important to know that this program is being sponsored by AstraZeneca. Our objectives today will be to talk about the burden of chronic kidney disease, management options for chronic kidney disease. We'll look at how to treat the complications of chronic kidney disease and the indications for referral to nephrologists. And as Dr. Damwa said, sometimes it's not fully referring, but for coordinated care as well. So chronic kidney disease, as defined by KDIGO 2012 guidelines, is abnormality of the kidney structure or function for more than 3 months with implications for health. Globally, looking at the trend of the global burden of chronic kidney disease, there are over 800 million people with chronic kidney disease as of 2017. And this is approximately 1 in 10 people all over the world. Chronic kidney disease, that has already been mentioned, is more prevalent in individuals with diabetes, in racial minorities like Blacks, in the elderly, and in patients with hypertension. And in terms of the death rates, there's been an increase in the death rates in patients with chronic kidney disease. So looking at 2013, it was the 19th cause of death worldwide. And this has gone up to the 12th cause of death as of 2017. And it's projected that by 2040 to be the 5th cause of death from patients all over the world. In Kolebu in 2019, it was actually the leading cause of death in patients in the emergency. So it shows how chronic kidney disease causes a lot of mortality and morbidity. And CKD is also prevalent in low and middle income countries like Ghana. Here in Ghana, the prevalence of CKD is about 13.3%, and this was in a publication by Prof. Boima et al. And CKD here in our part of the world commonly affects young people, usually patients in their reproductive age, patients in the working class, usually between 20 to 50 years. And studies have shown that here in that part of the world, we get CKD about 20 to 30 years earlier than compared to patients in Europe. And these are the bedrock of the country. These are the working class of the country. And if they are to be burdened with this disease, which has implications for their health and which can cause a lot of morbidity, it's something that can affect our country as a whole. Dr. Tano et al. In 2018 showed that about 71% of patients with chronic kidney disease present very late, mostly because they might not have money, there's lack of awareness because of our health-seeking behaviors. So most patients present at a stage where not much can be done and they have to go straight to kidney replacement therapy. This table shows the causes of CKD here in Ghana, which was by Prof. Boima et al. And though worldwide, the leading cause of CKD is diabetes, the study here showed that hypertensive renal disease was the commonest cause of chronic kidney disease, followed by diabetic nephropathy, and followed by glomerulonephritis. There's also this chronic kidney disease of uncertain etiology, which was the 4th common cause of CKD. Most of these patients presented at a very late stage. We say they crash landed, such that we're not able to do much investigation, such as a biopsy, to ascertain the cause of the kidney disease. And most of these patients did not have the traditional risk factors like hypertension and diabetes or any obstructive condition. And so they were classified as patients with uncertain etiology. Probably if they had presented earlier, further investigations might have been done, a kidney biopsy might have been done, and we could have been able to ascertain the cause of the kidney disease. And looking at this group of people, they presented, and they were quite a large chunk of people. And looking at the median age of presentation, it was about 45.5 years. And that is young compared to Europeans who are getting CKD above 60 to 70 years. So this calls for action. There is a conceptual framework that has been put in place by Kedaigo, and this has even been mentioned by Dr. Damwa in her previous talk. It's important for us to identify the high-risk patients in the population. And in identifying these high-risk patients, they are screened for chronic kidney disease. If the patients are screened for chronic kidney disease and there's no chronic kidney disease, you can rescreen either annually, especially in high-risk patients. If the patients are screened for chronic kidney disease and you diagnose CKD, then you re-stratify these patients, and we'll talk about the various re-stratification and prognosis, and also go ahead and treat. And it's important to note that during this whole process, the patients, the family, and the provider should be educated so that they know what to do. They know the lifestyle implication, the lifestyle modification to put in place, and they understand what is being done for them. These are the risk factors for chronic kidney disease. We have the common risk factors like diabetes and hypertension, cardiovascular diseases such as heart failure. It's also important to note that anybody with a prior acute kidney injury is at risk of chronic kidney disease. So once a patient has AKI, it's important for the patient to be followed up lifelong because there's risk of chronic kidney disease. And depending on the stage of the AKI, we have various, initially you might have to see them much earlier, but even if they fully recover, at least annually, such patients should be seen and screened and followed up. There are also people who live in certain geographical areas who are at risk of CKD. We have something we call CKD-U or CKD unknown or Mesoamerica CKD, and this is in certain population in Central America. Here in our part of the world, in Sub-Saharan Africa, we have a high prevalence of genetic variants of APOL1. And we have a lot of studies and going on both in Kolebu and in Konfanoche, where we are seeing a lot of patients with these high-risk variants. And there are actually new drugs available, and there are trials being done to see how best patients with these high-risk variants can be helped. And there are certain environmental exposures to that increases risk of chronic kidney disease. Genitourinary disorders such as structural urinary tract disease, recurrent kidney stones also increases risk of chronic kidney disease. Certain multisystemic diseases or chronic inflammatory diseases like SLE, vasculitis, and HIV also increase risk of chronic kidney disease. We also have iatrogenic causes, which can be drug-induced nephrotoxicity, the NSAIDs. Even certain antibiotics, such as aminoglycosides, can increase your risk of chronic kidney disease, radiation exposure, and the like. Also, family history or known genetic variants. And these include genetic abnormalities like polycystic kidney disease, APOL1 mediated kidney disease, Alport disease, and the likes. Gestational conditions also increases risk of chronic kidney disease, like preterm birth. So when babies are born preterm, they start off with a lower number of nephrons compared to term babies, and that can increase their risk of getting what we call adaptive FSGS and increase their risk of getting chronic kidney disease. Babies who are small for gestational age, and then mothers with preeclampsia and eclampsia also have increased risk of developing chronic kidney disease. Occupational exposures, such as exposure to heavy metals, mercury, lead, the galamsey and the lead and all the things that they use, it increases risk of chronic kidney disease. Polycyclic hydrocarbons and pesticides, all these things increases risk of chronic kidney disease. So it's important to identify all these risks and then screen these patients. In screening patients, the main things we do is to test to screen with both the testing the serum creatinine and or the cystatin C and calculating the estimated GFR or the estimated glomerular filtration rate, and also screening the urine for albuminuria and calculating the urine albumin creatinine ratio. As we said initially, in chronic kidney disease, you should be able to establish that the condition has been prevalent for 3 months or more. Sometimes it can be a bit difficult to do that, especially if you don't have a background or you don't have a baseline kidney function for the patients. There are certain things that can show or prove that the patient's kidney disease is likely to be chronic. One is if you have a history of prior measurements or estimated GFR, if you have history of past measurements of their urine albumin or proteinuria or urine microscopic examination, that can tell you that this patient's kidney disease is likely chronic. Because if the patient presents to you now and about 6 months ago, the patient had a reduced GFR, then you know that this thing has been going on for more than 3 months. So the patient has chronic kidney disease. If the patient comes and you do an ultrasound and the kidney sizes are small, or there's reduction in the cortical thickness, that shows that whatever is going on in the kidney is chronic. If you have the leisure of doing a kidney biopsy and you see features of fibrosis and atrophy, that also shows that there's likely chronic kidney disease. Also, certain patients with certain risk factors can also, the patient's medical history, the patient is a diabetic for more than 5 years, hypertensive, poorly controlled hypertensive, all these things can let you think that whatever the patient is presenting with is likely chronic kidney disease. And it's important because assuming chronic kidney disease with just a single value of eGFR can sometimes have implications, because once you label a patient as chronic kidney disease, it has implications for health. And it could be that the patient is having an acute kidney injury, or the patient is having what we call an acute kidney disease, which is a kidney injury that is more than that is usually between a month and 3 months. And such people should not be labeled as chronic kidney disease. So it's important to note that whatever the patient is presenting with is chronic. Once you do your blood investigations and your urine, you categorize the patients on this table. And this table is very important. And it's important because it shows the various risks associated with the patient's presentation. And it's also important because it shows us that we do not rely on just the eGFR. A patient might have a normal eGFR, but with severely increased albuminuria, that patient is at high risk. So it's important to do these tests together. And based on that, you categorize the patients into the G1 to G5. And it's important to know that in G3, we have the G3A and the G3B. The green shows that the patient has less risk. And then the yellow is moderate risk. The orange is a high risk, and the red is very high risk. And these are prognostic in patients. So in managing a patient with chronic kidney disease, The aim is to be able to manage the chronic kidney disease manifestations and outcomes in order to modify the natural cause of the chronic kidney disease and its symptoms. The manifestation, you look at prevention and treatment of the clinical signs and symptoms, including their blood pressure, maximizing their health-related quality of life and physical function, also monitoring and treating the laboratory abnormalities associated with chronic kidney disease, such as CKD, mineral bone disease, anemia, potassium disorders, and acidosis. And also, we look at minimizing the risk of progression of kidney failure and managing the risk and appropriate treatment of complications such as cardiovascular complications, hospitalization, gout, and infection. This holistic approach to CKD management and risk modification by Kihedaigo shows that CKD management is a multidisciplinary approach. It involves the physician, it involves the dietitian, and other healthcare professional with the patient and the caregiver as the center. And it involves various aspects such as lifestyle modifications, first-line medication, and even targeted therapy. And it's important to regularly reassess these patients every 3 to 6 months to see how well they are doing. And we'll go through all these things. So in lifestyle modification is one arm of the management that we look at. The next thing is management to slow down the progression and to reduce complications of chronic kidney disease. And this includes treating the hypertension of the patients, treating diabetes, and then treating complications such as anemia, hyperkalemia, metabolic acidosis, and CKD, mineral bone disease. The third arm is to reduce cardiovascular complication, and chronic kidney disease is an independent cardiovascular risk factor. So it's important to make sure that the patient's blood pressure is at target, and in some cases, lipid-lowering therapy and aspirin may be indicated. So in every patient we see and diagnose chronic kidney disease, the first thing to institute is lifestyle modification. And lifestyle modification include one, restricting salt intake. So patients are usually advised to restrict salt intake to about 5 grams per day of salt. 5 grams per day of salt can be difficult to say. So you can just tell them that they should restrict to less than half a teaspoon of salt. That is easier for them to understand. Also, no added salt to the table. So the men who like to add extra salt to the table to make the soup taste nice, they should be advised against that. Also, reducing the intake of salted foods like poppy and momoni and kapo, because these foods sometimes are laced with a lot of salt and they can increase your regular salt intake. Our patients should also be advised on a balanced diet. And we usually advise them to consume more plant-based food than animal-based food. And they should consume less highly processed foods. And they should increase their intake of fruits, vegetables, and also reduce intake of carbohydrates. Patients should be advised on moderate intensity physical activity, a total of about 150 minutes per week of exercise. Moderate intensity exercise is advised, and that translates to about 30 minutes a day, 5 days a week. Actually, there was also a study that compared the 150 minutes per week, whether you spread it 5 days a week or you do the weekend warriors like some of us. And they realized that weekend warriors and those who do the 5 days a week, there was not much change. So if you're a very busy person and during the week you can't go brisk walking or jogging, over the weekend you can still do your exercise and you still achieve the same effects. Patients are also encouraged to reduce weight and with a BMI target of less than 25 kilograms per meter squared. We also live in a very hot, humid environment, so patients should be advised to hydrate well. especially during the warm weathers. They should stop smoking or taking any tobacco products, whether it is cigarettes, whether it's shisha or flavored tobacco or chewing tobacco. They should stop all those things because all these things can cause CKD. They cause a lot of inflammation and damage to the kidneys. And also advise on the use of unlicensed herbal medication and the use of indiscriminate or prolonged use of analgesics, especially NSAIDs. And here in Ghana, unfortunately, people can buy NSAIDs over the counter. People buy NSAIDs every day for headaches, and in the long term, they have adverse effects on the kidney. So patients can be cancelled. Our market women, our drivers, they should all be cancelled on the indiscriminate use of medications. In slowing down the progression, we first talked about our blood pressure control. And for the target blood pressure in adults with CKD, the systolic blood pressure target is less than 120 millimeters of mercury. If the patient, if you are having difficulty, you can go up to 130, but usually the appropriate target is less than 120 millimeters of mercury. In patients who are frail or who have symptomatic postural hypotension, you can do a less intensive blood pressure target. For patients with diabetes, the target fasting blood sugar should be between 4 to 7 millimole per liter, but this can be adjusted upwards in the elderly because of the risk of hypoglycemia. So in the elderly, you can go up to about 6 to 8 millimoles per liter. And the target glycated hemoglobin should be 7%, but in those with early CKD, stage 1, stage 2, you can even target lower to about 6.5%. There have been some pharmacological therapy which have been shown to reduce CKD progression and also to reduce cardiovascular complications. And these drugs include the renin-angiotensin inhibitors, such as the ACE inhibitors and the ARBs, the sodium glucose cotransport 2 inhibitors, the glucagon-like peptide 1 receptor agonists, and the mineralocorticoid receptor antagonist. So we'll go through all these, evidence-based pharmacological therapies, and we'll look at the current guidelines for all these therapies to help us in managing our patients who present to us with chronic kidney disease. The first one we talk about is the renin-angiotensin system inhibitors. So these RAS inhibitors include the angiotensin converting enzyme inhibitors, that's our ACE inhibitors, and the ARBs and the direct renin inhibitors. So ACE inhibitors, they usually block the angiotensin converting enzyme, which converts angiotensin 1 to angiotensin 2. The ARBs block the angiotensin 2 receptors. This kinase, so it's important to note that since we have a lot of residents here, angiotensin 1 can be converted to angiotensin 2 by the ACE, and then there's a non-ACE independent pathway called the kinase. So this kinase is a protease that can convert angiotensin 1 to angiotensin 2. So they did some research and they realized that some patients on ACE were having limited effect of the drug, and they found this protease called the kinase in the mice model, and that protease can convert angiotensin 1 to angiotensin 2, and that is what we call the angiotensin escape. So I just brought it there for us to see that as well. So the main effect of these ACE and the ARBs is to cause efferent arterial vasodilation. So normally the angiotensin 2 causes more of efferent arteriolar vasoconstriction. So once you inhibit that, you cause efferent arteriolar vasodilation, and in effect, you reduce the glomerular filtration pressure, and that also results in a reduction in albuminuria. There are also other positive effects, such as reduction in oxidative stress, reduction in inflammation, apoptosis, and fibrosis, and an increase in nitric oxide production as well. Evidence have shown the beneficial effects of ACE and ARBs on both the kidney outcomes and cardiovascular events in patients with CKD. So this meta-analysis involving more than 64,000 patients with CKD, with or without diabetes, showed the beneficial effects of ACE and ARBs compared to placebo in patients with kidney disease. And when we look here, we realize that those with ACE and ARBs all had beneficial effects on kidney failure compared to placebo. And this was also the same as with the cardiovascular events. And that shows the beneficial effects these drugs have on both the kidney outcomes and cardiovascular events. So from our KDIGO 2024 guidelines, these RAS inhibitors should be started in patients with chronic kidney disease with moderately to severely increased albuminuria with or without diabetes. So anybody with CKD with urine albumin creatinine ratio more than 30 milligram per gram with or without diabetes should be started on RAS blockers. And the RAS blockers can also be started in patients with normal or mild albuminuria to treat hypertension or heart failure with reduced ejection fraction. So in a hypertensive with CKD, RAS blocker should be one of the first medication you start the patients on. And it's important to note that if the patients are on ACE inhibitors and ARBs and their GFRs fall to less than 30 mils per minute, these drugs should be continued because their beneficial effects on the cardiovascular system and on the kidney is marked. Sometimes people complain about hyperkalemia, but in that case, you have to make sure that you have also ruled out all other causes of hyperkalemia, and stopping these drugs should be the last thing you do unless there are no contraindications. In monitoring a patient on ACE or ARBs, it's important to know that once you initiate these drugs, it can cause some increase in the serum creatinine. And it's important to monitor the serum creatinine and potassium within 2 to 4 weeks after starting the drug or even changing the dose. And once you start the drug, you monitor the potassium level, you monitor the kidney function. If the potassium is normal and the kidney function decline is less than 30%, you can then continue the medication and adjust it appropriately because it can cause a slight decrease in kidney function, but usually less than 30%. If the patient, however, develops hyperkalemia, you have to review concurrent medications. If the patient is taking excessive amount of potassium, if the patient is on certain medications that can increase the potassium levels, like the potassium sparing diuretics and the rest. And you should consider giving medications to reduce the potassium first before you stop these drugs. So once you consider giving the medications to manage the hyperkalemia and the hyperkalemia persists, then you can adjust the ACE inhibitors or stop them. If the patient's kidney function decreases to more than 30% after initiating or changing the dose, you have to review for causes of acute kidney injury, such as volume depletion, and then concurrent use of certain drugs that can increase nephrotoxicity, and also consider conditions like renal artery stenosis. Once all these have been ruled out and the GFR has reduced significantly, you can review or stop these medications. The next medication we'll talk about is the sodium glucose cotransporter 2 inhibitors, or the SGLT2 inhibitors. So these drugs work on the proximal convoluted tubule by inhibiting the sodium glucose cotransporter 2. So what this transporter does is that it causes the reabsorption of about 90% of the filtered glucose and also sodium. And the glucose eventually gets into the blood through the basolateral surface through the GLUT2 channel. So once the SGLT2 is inhibited, it results in the loss of sodium and glucose through the urine. As the sodium and glucose goes through the urine, it is sensed in the macula densa, and that causes a tubuloglomerular feedback, resulting in a constriction of the afferent arterioles. As the afferent arterioles constrict, it results in a decrease in the intraglomerular pressure. It reduces intraglomerular hypertension, and it reduces proteinuria. So there are a lot of potential mechanisms that leads to the kidney protection of the SGLT2 inhibitors. It reduces intraglomerular pressure, and it reduces proteinuria, it reduces blood pressure. It also improves metabolic parameters like reducing HbA1c and the weight. It also has anti-inflammatory and anti-fibrotic effects as well, and it increases oxygenation of tubular cells as well. Studies with the SGLT2 inhibitors have shown that they reduce cardiorenal outcomes in patients with chronic kidney disease. There have been a number of studies. We have the Credence study, which was done with canagliflozin, and this involved patients with type 2 DM who had the GFR between 30 to 90, and it showed a reduction in cardiorenal outcomes. We have the DAPA-CKD trial, which was in patients who had diabetes and even patients who did not have diabetes, with a GFR between 25 to 75, and that also showed a reduction in cardiorenal outcomes. And we also have the EMPA kidney studies. All these studies have shown that SGLT2 inhibitors reduces cardiorenal outcome in patients with CKD, with or without diabetes. So the zooming on the DAPA-CKD trial. So this was a trial that was done between February 2017 and June 2022, and it involved about 4,000 plus participants in about 383 sites, and it included patients who had a GFR between 25 to 75 with a urine ACR between 200 to about 5,000 milligrams per gram. And these patients were stable on ACE inhibitors or ARBs for more than 4 weeks. So the DAPA-CKD trial that was done, as I said, it involved both patients without diabetes and patients with diabetes. About 32% of the patients did not have diabetes. And the primary endpoint was a composite of a sustained more than 50% decline in the eGFR, end-stage renal disease, renal or cardiovascular deaths. And these were the secondary endpoints. And it showed that putting the patients on dapagliflozin reduced the primary endpoints, and putting the patients on dapagliflozin also reduced the secondary endpoints as well. This tortoise and the hare re-imagined by Alejandro et al. Shows how beneficial SGLT2 inhibitors are in the progression of chronic kidney disease. So they took patients on the Credence trial, and these patients, when on only RAS inhibitors, had about 4 to 6 mils per minute drop in GFR per year, such that in about 10 years, the patient's eGFR had dropped to less than 10. Compared to patients who were on SGLT2, their drop was slower, similar to a tortoise, of about 1.85 mils per minute per year. And their drop was about 15 years more than those in the RAS inhibition. So in patients on SGLT2 inhibitors, their eGFR dropped to less than 10 in about 25 years from the start point of the study. And that showed that SGLT2 inhibitors added an additional 15 years of freedom from end-stage kidney disease, and that showed the importance of SGLT2 inhibitors. Earlier on in the initiating of therapy, there's a slight drop in the GFR with SGLT2 inhibitors, but with time, looking at the overall drop, the GFR drop with the SGLT2 inhibitor is very slow compared to patients on ACE inhibitors alone. So all these things informed the KDIGO guidelines for 2022. And for patients with CKD, it's the guideline we recommend that SGLT2 inhibitors should be given to patients with type 2 diabetes and CKD and an eGFR of more than or equal to 20 mils per minute. And once you initiate these SGLT2 inhibitors, they should be continued even if the GFR falls less than 20, unless they are not tolerated. It's, however, important to withhold SGLT2 inhibitors in times of prolonged fasting, surgery, or critical illness due to risk of ketoacidosis. And during these times, too, the patient might not be able to drink as much water and are at risk of acute kidney injury. SGLT2 inhibitors should also be given to patients with chronic kidney disease, even without diabetes, if they have eGFR of more than 20 with a urine ACR of more than 200 milligram per gram, if they have heart failure, irrespective of the albuminuria level, and if they have GFR of 20 to 45 with a urine ACR of less than 200 milligram per gram. So SGLT2 inhibitors is now one of our first-line medications to go to in managing our chronic kidney disease patients. The next class of drug we'll talk about is the mineralocorticoid receptor antagonist. The mineralocorticoid receptor antagonist acts to inhibit the mineralocorticoid receptors, and in doing so, they prevent aldosterone from binding to these receptors, and this in turn prevents the activation of the ENaC channel. There are two main types of mineralocorticoid receptor antagonists. We have the steroidal and the non-steroidal. The steroidal include spironolactone and eplerenone, and the non-steroidal are the newer ones like finerenone. This study showed that finerenone, which is the non-steroidal MRA, has cardiovascular mortality benefits in patients with type 2 DM. So this study was done in about 5,000 plus patients with type 2 diabetes and CKD, and they compared finerenone with placebo, with a primary composite outcome of kidney failure with more than 40% decrease in GFR over a 4-week period or death from kidney renal causes. And in following the patients up for about 2.6 years, they realized that finerenone had a positive outcome, decreasing the kidney failure rate compared to placebo. So in patients on finerenone, only 17.8% had the primary composite outcome compared to 21.1% of patients with placebo, and it was statistically significant. So they concluded that in patients with CKD and type 2 diabetes, treatment with finerenone results in lower risk of CKD progression and cardiovascular events compared to placebo. The current guideline therefore states that non-steroidal MRAs such as finerenone can be added in patients with type 2 DM and CKD with an eGFR of more than 25, normal potassium, albuminuria of more than 30, despite maximally tolerated dose of RAS inhibitors. So these can be add-on medications to patients if they are on maximally tolerated RAS inhibitors, but we are still not achieving our effects. The steroidal MRAs like spironolactone can be used in patients with heart failure or refractory hypertension or hyperaldosteronism. The risk compared to the non-steroidal MRAs are hyperkalemia and a reversible decline in GFR. The last group of medications we talk about are the GLP-1 agonists, that's the glucagon-like peptide 1 receptor agonists. So these drugs are mainly work by increasing GLP-1, and GLP-1 normally is released when there's food in the stomach, and the release of GLP causes the pancreas to increase insulin, and they also causes the brain to reduce appetite, causes the stomach to inhibit gastrin emptying, and it also inhibits glucagon secretion. These GLP-1 agonists have been shown to also have a positive kidney outcomes, and meta-analysis have shown that the primary outcomes are lower in patients who are on GLP-1 compared to placebo with or in patients who have diabetes and in patients who are obese. So currently, it is recommended that the GLP-1s be used in patients with type 2 DM or CKD who are not achieving glycemic targets despite the use of metformin and SGLT2 inhibitors, and those who are unable to use these medications. This diagram shows the various treatment approaches that we've spoken about in patients with diabetes and chronic kidney disease. So in a patient presenting with chronic kidney disease and diabetes, the first thing we do is lifestyle modification. And the first line therapy for patients is metformin if the GFR is more than 30, and SGLT2 inhibitors if the GFR is more than 20. And these drugs should be continued even if the GFR falls. You should regularly assess the glycemic, the glycemia, albuminuria, the blood pressure, cardiovascular risk, and lipids. If on these two medications, the sugars are not well controlled, you can add on a GLP-1 receptor agonist. And if on the GLP-1 receptor agonist, the sugars are not controlled, then you can add on other glucotrol drugs. For the blood pressure, it's important to start first with your RAS inhibitors. If the blood pressures are not well controlled, you can add on the non-steroidal mineralocorticoid receptor agonist in patients who have diabetes. If not, you can add on your CCBs and then your diuretics. And if you are not achieving blood pressure targets, you can add on the steroid MRAs. And then cardiovascular risk is also important to assess the risk. And this is what we'll talk about in our next slide. So we've spoken about the lifestyle modification. We've spoken about management to reduce CKD progression. The last arm we'll talk about is management of cardiovascular disease risk. And it's important that in patients with chronic kidney disease who are more than 50 years, you start them on a statin if their EGFR is less than 60. If their patients are between 18 to 45 and 49 years, you only use a statin if they have one of the following: if they have a history of coronary artery disease, such as an MI or coronary vascularization, if they have diabetes, if they've had a previous stroke, or if their 10-year estimated incidence of coronary mortality or non-fatal MI is more than 10%. You only use low-dose aspirin to prevent recurrent ischemic cardiovascular events in patients with CKD and establish ischemic cardiovascular disease. So moving on, we've talked about the lifestyle modification, what to do to slow down the progression of kidney disease. We've talked about how to manage their cardiovascular risk. And now we'll look at the complications that chronic kidney disease patients can present with and how to manage them. So the first we talk about is metabolic acidosis, and this is defined as a serum bicarbonate of less than 22 millimole per liter. In managing patients, the first thing is nutritional approach. The patient can be counseled to reduce their intake of animal protein and increase intake of plant protein, fruits, and vegetables. Bicarbonates can be instituted, mostly oral bicarbonates. If the serum bicarbonate is less than 22, the target bicarbonate of 24 millimole per liter. And you can usually start at a lower dose and increase the dose as appropriate. It's important to note that if you start a patient on bicarbonate, you monitor for the volume status, because there's risk of volume overload because of the sodium content in the sodium bicarbonate. So you have to monitor the blood pressure. You have to listen to the lungs for any pulmonary edema, look at the legs for edema and all that. The next thing, the next complication we talk about is hyperkalemia. And hyperkalemia is defined as a serum potassium level of more than 5.5 millimole per liter. In defining hyperkalemia, we have to look at several factors that can increase the serum potassium, and they include: one, pseudo-hyperkalemia. You need to rule out pseudo-hyperkalemia. Look at how the blood was drawn. Was the tourniquet too tight? Did the patient clench the fist for too long? How was the blood even stored? Was it a hemolyzed sample? Because all these can cause pseudo-hyperkalemia. The hyperkalemia can also be from shifts of potassium from the cells, whether the patient has some excessive muscle breakdown like rhabdomyolysis or is dehydrated, or the patient is on certain medication that can increase the risk of getting hyperkalemia. And these are examples of medication that can cause hyperkalemia, such as ACE inhibitors, ARBs, and all that. So you have to rule out all these things in patients who present with hyperkalemia. So if your patient comes in with a high potassium, how was the sample taken? Is the patient on any concurrent medication that can increase the risk of hyperkalemia? You have to look out for all these things and make sure that you stop all these medications and see how the potassium goes. In the outpatient management of hyperkalemia, the first is the dietary intervention. The patient has to reduce intake of potassium-containing foods, like foods such as coconuts, and then avocado, certain vegetables. The next is potassium exchange resins, such as calcium resonium, kiexalate, and the newer drugs such as sodium zirconium. And we also have the new ones like papilloma as well. It's important to note that when you are giving these medications, you add a laxative like lactulose to prevent constipation and also gut necrosis. If the patient has a normal kidney function, you can give a loop diuretics. And as I said, you review the patient's medication and consider stopping any concurrent medication that can increase risk of hyperkalemia, as previously stated. In refractory cases, the hemodialysis might be instituted. So this just shows the various exchange resins and how they work. The commonest one we have here is the calcium resonium, which exchanges calcium for potassium for calcium. We also have the sodium resins as well. We also have the newer ones like pahatiroma, which exchanges potassium for calcium. And then we have the sodium zirconium, which also exchanges potassium for sodium. And as I said, the side effects are mostly GI side effects like constipation. They can cause nausea, vomiting, and intestinal necrosis. And they can also cause electrolyte imbalance like hypokalemia, hypocalcemia, and like. In the emergency management of hyperkalemia, if a patient comes in with hyperkalemia with a serum potassium of more than 6.5, the first thing you want to do is one, look for any ECG changes of hyperkalemia, like your tall tented P waves and the like. And you want to stabilize the heart with 10 mL of 10% calcium gluconate. And subsequently, you want to shift the potassium into the cell. So you quickly stabilize the heart, and then you start shifting the potassium into the cell urgently. You can use your insulin with dextrose, either 5 units of insulin in patients with kidney failure, but in patients normal kidney function, you can use as much as 10 units of soluble insulin. And then you give 50 mL of 50% dextrose infusion. It's important to monitor for hypoglycemia, especially within the first 3 hours. So you monitor hourly for hypoglycemia because patients are at risk of hypoglycemia in the first 3 hours after giving insulin to shift the potassium into the cell. Other modalities to shift the potassium include nebulized beta-2 agonists such as salbutamol. And since these are shifting the potassium into the cell, the potassium is likely to come back. So you can repeat these multiple times. And you also have to find a way of eliminating the potassium from the body, either through the GIT or through the urine or by hemodialysis. So this is the ECG changes. So in terms of the GIT, sometimes you can in terms of the GIT, unfortunately, in the emergency setting, the GIT route usually takes a while. So you might not be able to get that working as soon as possible. But doing hemodialysis can quickly remove the potassium, especially in patients who have kidney failure. And as you are shifting the potassium into the cell, you have to be monitoring the patient. Such patients should be on a cardiac monitor so that you can monitor for any changes that can occur. The next complication we talk about is anemia. And anemia is defined as a hemoglobin level of less than 12 grams per deciliter for female and 13 grams per deciliter for male. And CKD patients are at risk of anemia of chronic kidney disease. They have low production of erythropoietin, they have shortened red blood cell survival and the likes. In managing patients with CKD with anemia, The first thing is to replenish the iron stores. So we usually do our iron studies where we look at the transferrin saturation and the ferritin. If the transferrin saturation is less than 30% and the ferritin is less than 500, we initiate iron therapy. And the iron therapy can either be oral or IV. In most patients who are not on hemodialysis, we institute oral therapy. The IV therapy is when it's instituted if the oral therapy is not satisfactory, or if there's less response to the oral therapy. And as the patient is on the iron therapy, there has to be review of red blood cell indices like full blood count, MCV, MCH, and the likes. Also, patients should be encouraged to take in green leafy vegetables to help also produce more iron. If the iron stores are adequate, we can initiate erythropoietin stimulating agents in patients whose HB are less than 10, with a target HB between 10 to 11.5. And it's important to monitor the hemoglobin levels every yearly for patients with CKD, stage 3, every 6 months, and then every 3 months. And for dialysis patients, we even sometimes do a monthly review of the hemoglobin level. The last complication we'll talk about is calcium and phosphate abnormalities. In chronic kidney disease patients, they are at risk of calcium phosphate abnormalities and chronic kidney disease, mineral bone disease. And they can present with elevated parathyroid hormone and abnormalities in the calcium, with low calcium and high phosphates in secondary hyperparathyroidism. And all these things can cause bone weakness. In managing them, the first thing is to restrict dietary phosphate restriction, either with restricting dairy products. And even a lot of these processed foods and canned food contain high amounts of phosphate as well. Subsequently, oral phosphate binders are given to the patients. The common ones are the calcium-containing phosphate binders like calcium carbonate. We also have the non-calcium containing phosphate binders like cesabilame and lanthanum carbonate, but these are quite expensive and are difficult to get in our parts of the world. In patients with elevated parathyroid hormone levels, vitamin D analogs and calcitriol can be given to suppress the parathyroid hormone level. But this can also be done in consultation with nephrologists as well. So when can you refer to the nephrologist for management and for coordinated care? When the GFR drops less than 30 mL per minute. If the patient presents with uremic complications because the patient would need urgent hemodialysis, if the patient has persistently high urine albumin creatinine ratio, if the patient has an acute kidney injury or an abrupt sustained fall in the GFR, if the patient is presenting with an atypical progression of chronic kidney disease, that is somebody who is presenting with a rapid decline in the GFR, more than 3 mL per minute per year. If the patient has refractory hypertension, if the patient has unexplained persistent hematuria, if the patient has certain persistent abnormalities such as potassium or sodium, if the patient has any hereditary kidney disease, recurrent or extensive nephrolithasis. These are all indications when the patient can be referred to the nephrologist. As Dr. Nketia said, we might not be available in all hospitals, but sometimes we are just a phone call away. Sometimes you can just call for the discussion so that we can see how best we can manage the patient, because there are so many patients and it's difficult to see everybody. But in certain jurisdiction, there's a lot of the discussion that goes on, such that nephrologists might not be present in certain centers. But once the primary care doctors there discuss with them, they're able to manage patients appropriately until the patient needs some form of renal replacement therapy. And then that's when they can come for the nephrologist to see. So we also have numbers available to Dr. Nketia, and we are always available. So these are all things that can be done easily. So in conclusion, I would say that chronic kidney disease, as we said, is a very prevalent disease with a high mortality. Now there are modalities to slow disease progression. And it's important for us to know and manage these patients appropriately to reduce the risk of progression to end-stage kidney disease. Thank you very much.
Thank you very much, Jose. Jose, I know you can take over another
Yes, we can.
Tough. To collaborate. They are tough to coordinate. And they know how to do it very well. I'm sure I'm not clear. Most likely it's on.
Yes.
The channel is on. Challenge is on. Our call is on. This is a big challenge, but I would say that such a good presentation. If there could be a general line, I'm not a cardiovascular society have a call center, but it's a challenge that I'm also showing to the society from whether they can see a call center. Because as I said, you cannot see all of them, but probably there's a call could guide the management, and that could be a very welcoming help for both the doctor and the patient with managing. And I can tell you very much. There are three, let's say 4 main lines: managing lifestyle, reducing the progression, Thank you very much, Aposha, for such a great presentation. 4 main areas she talked about. That we are managing the lifestyle, making sure that we are reducing the progression, and knowing how to manage the complications. I hope we've taken the notes well, and I hope that next, I'll say that put all your questions in the Q&A section. We have the number, so keep it coming so that we can solve all your problems for you. Don't live here with questions, issues that are unanswered. You need to live here, be capable to manage all your. They've been great partners over the past years, over 5 to 10 years that we collaborated. We really appreciate. They are bringing our way this CPD program, and they have. I think I could in reducing the progression of CKDs, and they are here to give us a presentation on some to you as you manage your patient with CKD. AstraZeneca, number 4.
Good afternoon, esteemed colleagues. My name is Dixon Frokletowusu with AstraZeneca. I'll be presenting on Forxiga as a drug of choice for the management of CKD and also diabetes. I will start with how Forxiga came about, and because Dr. Akosua and Dr. Amua Dr. Damwa kept on mentioning diabetes. I'll start with diabetes and I'll end it with the CKD. Forxiga, as Dr. Akosua said, it works by blocking the proximal convoluted tubule, not allowing 90% of your sugars to be reabsorbed back into your bloodstream. And with this, there's also about excess of 70 grams per day of glucose that is excreted. Because of this mechanism, Forxiga has 3 main primary benefits, which is glycemic control, and with the further slides, we'll see how best it does its glycemic control. It also causes weight loss, and because of that, 280 kilocalorie per day that is burnt. And if you are trying to lose weight just like myself, you understand that burning 280 kilocalories per day without exercise or diet is highly significant. It doesn't end there. Because of the high properties high osmotic properties of blood pressure, high osmotic properties of glucose, it comes out with water. So there's mild diuresis, which will lead to blood pressure reduction. We know that from the presentation that has come earlier, we've seen that hypertension in Ghana has the highest cost, whilst worldwide diabetes has the highest cost. So if you have a drug like Forxiga that is doing good glycemic control, it's giving you weight loss, because we saw that one of the effects is also obesity, and Dr. Akosua spoke about losing weight. And this drug is giving you glycemic control. It's also giving you weight loss. It doesn't end there. It's giving you mild blood pressure reduction. I think it's significant. When you take Forxiga and you compare it to the sulfonylureas, which is the traditional medicine that is used to manage diabetes, you realize that at 52 weeks, where a study was done between Forxiga and sulfonylurea, that's the new generation sulfonylurea, you realize that Forxiga at the long term will give you better HbA1c control than the sulfonylureas. When you start, you see that the sulfonylureas will give you better HbA1c control because there's a high dip in HbA1c control. But Forxiga does it smoothly. Forxiga is very loyal. It's going to stay with you for a long time, causing a consistent HbA1c drop. But for sulfonylureas, with time, the HbA1c begins to go up again, and you will need to change the medication, add on or increase the dose. Also, the risk of hypoglycemia is least with Forxiga. If you compare it to the sulfonylureas, it gives you nearly 10 times less incidence of hypoglycemia. And when it comes to weight loss, when you compare the modern sulfonylureas like glipizide, they say that the newer sulfonylureas have less weight loss. But if you compare that one to Forxiga again, you're having about 4.38 kilogram weight loss. This has got nothing to do with diet and exercise. And as I said earlier on, if you should lose 4 kg, if you are obese and you lose 4 kg, it calls for celebration. And it's very important to lose this weight. It doesn't end there. When you compare it to also sulfonylureas, you have about 3.67 millimeter mercury loss, reduction in systolic blood pressure. And as we said, we know that every drop in, every 1 millimeter per mercury drop in blood pressure gives you significant reduction in cardiovascular complications. When you compare it to the latest oral antidiabetic like the DPP-4s, you realize that Forxiga reduces the HbA1c better than even your DPP-4s. So at the end of the day, Forxiga is giving you weight loss, it's giving you better glycemic control over time. If you compare it to the sulfonylureas and even the DPP-4s, it's also giving you better BP controls. It's adding a little touch to your blood pressure. It doesn't end there. You can add it to metformin, sulfonylurea, DPP-4. You can add it to every other drug. As I said, it's very loyal. It can attach to any molecule and you are going to get better response. This is because it has a non-insulin dependent mechanism of action. So it doesn't rely on insulin. And when you add it on to an insulin dependent molecule, it gives you a synergistic effect. Now, when you add it onto insulin, it helps you not to increase or decrease the dose of insulin. Because in this study, you realize that Forxiga plus insulin, you don't need to change the dose of your insulin. Usually, when you give insulin, most of the times you are scared that probably you're not going to get good glycemic control. So you keep on increasing the dose or you keep on decreasing the dose when the side effects set in. But when you add Forxiga to it, it doesn't just give you good glycemic control, but it also neutralizes the risk of the hypoglycemia that will come with your insulin and also neutralize the risk of the weight gain that comes with insulin. Because we know that when we give insulin, the two main headaches that we have as clinicians is we are scared of, would the patient go into hypo or would the patient have, or would the patient come up with weight gain? But Forxiga helps to neutralize those effects of the insulin. From all the benefits we spoke about, reducing risk of hypoglycemia, is able to bind to other drugs and work synergistically. It also reduces weight loss. It reduces weight. It reduces blood pressure and also has best glycemic control when compared to the other oral antidiabetic we spoke about. It doesn't end there. From the previous presentation, we realized that CKD has an interconnection with diabetes and not just that, also with hypertension. But from this study, you realize that this is a study of registries, different registries. They realize that type 2 diabetes alone is a potent independent risk factor for CKD and heart failure. And if you combine that two, it's about 60%, which is highly significant. And for Forxiga, you realize that Forxiga gives you significant reduction in all this. Apart from what we've spoken about, you realize that when you take heart failure alone, with or without diabetes, Forxiga tends to reduce the risk of cardiovascular complications, dying from your heart failure or hospitalization of heart failure. And also when you take this DAPA-CKD that Dr. Akosia spoke about, there's about 39% relative risk reduction when patients who are already on the standard of care for managing CKD. When Forxiga is added on, you also reduce the risk of about 39%. That's the risk of declining kidney function, end-stage kidney disease, and having a renal or cardiovascular death. When you take the patients who don't even have diabetes, you reduce this risk by 50%, not just. And if you take those with type 2 diabetes, you reduce the risk by 36%. This shows that diabetes alone is a very strong risk factor for CKD. So what we tell our clinicians, especially our primary physicians, is Forxiga is not a specialist drug. Forxiga is a primary physician drug. Why? Because we rob our patients of the benefits, especially if the patient is a diabetic patient. What happens to a diabetic patient is whether the patient has CKD or not, in the next 5 years, that patient is likely to come down with a CKD. And if you look at this slide, the slide that Doctor spoke about, the tortoise, you realize that she spoke about 15 years delay when you add probably Forxiga to the ARBs or the ARBs or the ACIs. But just look at this slide. When the EGFR has dropped to 60, the delay is about 11 years. When it drops to 30, the delay is about 6 years. Why am I stressing on this point? Primary prevention is very, very important. When the patient comes in and the patient is diabetic and the patient qualifies for Forxiga, let's not deprive that patient and start metformin and probably move to sulfonylureas and move to DP4 and reserve Forxiga as, oh, last line, when anything is not working, we know that you there, you work, then we'll bring you in. Let's start it early. Why? Because when you start early, you delay progression to end-stage kidney disease. And from the slides, the presentation we've had, you realize that when a patient gets to end-stage kidney disease, there is little you can do. And the burden that it comes with, Doc spoke about 144,000. I was just looking at myself and saying that if every month I'm supposed to spend about the years about 12,000 or 12K on just kidney transplant, on just dialysis, then it means that what is the average salary of a Ghanaian? What is the average salary of some of us in this room? It means that we need family members to contribute. But probably the average price of Forxiga falling in between probably 500, 600. That's monthly. And you compare it to about delaying this patient from getting to dialysis, where the patient will spend an average of 12,000, and it doesn't end there. Doc probably didn't even factor in the kind of drugs you use for this patient. When it gets to that point, that one you can't say, I won't buy. The moment you don't get that drug, the patient cannot undergo the dialysis. So if there's a room for primary prevention, where most patients and most families don't like because they wait for the condition to get severe before they try to manage it, it's best that the patient starts on Forxiga and prevent these delays that will lead to more cost at the end of the day. Now, all SGLT2s are not the same. Why am I saying this? Because it's only Forxiga that has proven to reduce all-cause mortalities in patients with CKD and heart failure. Other studies were not able to prove statistical significance in reduction in cardiovascular death and reduction in cardiac mortality in their trials for heart failure and CKD, except only Forxiga. And when you look at the safety of Forxiga amongst patients with type 2 diabetes and patients without type 2 diabetes, it's very similar. So it means that some doctors are worried that my patient doesn't have diabetes, but the patient has CKD. Can I start Forxiga in that patient? Yes, you can start Forxiga in that patient, because the things that you are scared of, like hypoglycemia, volume depletion, diabetic ketoacidosis, is not going to appear in that patient who doesn't have type 2 diabetes. This comes to end Forxiga, where it says that even with optimal A1C management, your patients are still at risk of diabetic nephropathy. But Forxiga is the SGLT2 that has shown consistency in renal protection for all your patients, regardless of EGFR, where the EGFR is not below 20, as Dr. Akosia said. And it also protects your patients from albuminuria progression. When it comes to saving lives, Forxiga has proven to reduce all-cause mortality in CKD patients with or without type 2 diabetes. Forxiga comes as a 10 milligram tablet. It can be taken any time of the day with or without food. Then we also have Zigdio, which is a combination of Forxiga and metformin. It comes in 2 packs, the 10-1000 and the 5-1000. The 5-1000 is 60 tablets. The reason why it's 60 tablets, that one is for patients who are on 1 gram metformin BD. In this case, they will swallow 2 tablets at a go. When you swallow the 2 tablets, you are going to get 10 milligram Forxiga and 2 gram or 2,000 milligram metformin at a go. But there's a special formulation with the tablet that you are swallowing that it gives you a consistent release of both the Forxiga and the metformin across a 24-hour period. Please, the Zigdio is never given BD. It's given once a day. The same with the 10 by 1,000 strength, where it's required for patients who are taking 500 milligram metformin in the morning, 500 milligram metformin in the evening. For the 10 by 1,000, when you take just one tablet, it's also daily. It's going to stay in your system for more than 24 hours. As I said, it's very loyal to your system. It's going to stay in your system consistently and give you the required dose of metformin and Forxiga across. Doc also spoke about starting dyslipidemia control in your CKD patients. For our patients, we should know this statement is very important. Any 1% reduction in LDL cholesterol reduces your coronary heart disease risk by 1%. But any 1% increase in your HDL cholesterol will reduce your coronary heart disease risk by 2 to 3%. The reason why I'm saying this is because when you want the single most powerful statin in reducing your LDLs, Crestor plays a very significant role. Why? Because the 10 milligram Crestor is effective according to the Stellar trial, or equivalently effective just in reducing LDL, just like your atorvastatin 40 milligram. And the Crestor 20 milligram significantly reduce your LDL, equivalent to your atorvastatin 80 milligram. So with that, you realize that when it comes to HDL, Crestor is the only one that increases HDL in your system as the dose also goes up. So from 5 to 10 to 20, you see a significant increase in your HDL. This happens because Crestor has the highest bonding interaction with HNG-CoA. It can be taken any time of the day. And when you have a patient who has very stubborn LDL levels, Crestor comes in handy in reducing it for that patient, especially when the patient is on other statins where you are not seeing significant reductions. And also when you have a patient that you want to increase the HDL, Crestor is the only statin that has shown that as you increase the dose, there's also HDL increase. I will end by saying, as a primary physician, let's not deprive our diabetic patients of Forxiga. Why? Because it comes in handy by reducing weight, increasing, reducing blood pressure, has the best HbA1c control across the oral antidiabetics that is on the market. Then finally, it helps also protect the heart and the kidney, which are the two most important organs that can lead to death. Thank you.
Thank you very much. I think that one of the presentation, somebody said that Forxiga is like a herbal medication. It does everything. So at the end, he summarized the many things that Forxiga is doing. Just to let you know that it's not a herbal medication, just that currently there's a lot of evidence that does a lot of things. And just take with them. Thank you very much for your presentation. There are a number of questions. We have just 30 minutes to go through the questions. But I'll just start with the last presenter. Because as we were going on, people were putting in what the cost. So at the end, I have to throw the question back to you. But so, what's the cost, of these nice medications which are not herbal but can do everything? The wonder drug. What are the costs for these medications?
Okay, thank you so much. So, Forxiga at the wholesale, for the retail, we don't decide the price, but at the wholesale, it costs 585 cedis for a monthly supply. And we are also running special discounts for a lot of hospitals across the country, whereby it's also reduced to 473 for the patient. Yes.
For the patient to take home. So if my client has 473 enter the facility.
Those special.
What
And
about
please, it's even open to all private and government facilities. There's just terms and conditions apply, but that one is by the side. But it's open. If you are working in a facility that you see a lot of diabetic patients, we can come in with an offer for that place. Thank you.
Thank you very much. You mentioned the question.
Yeah.
So that I can complete the cost.
So the Crystal 10, it runs around 260, 280. The 20 runs around 310, 320. But don't just look at the cost, look at the benefits that it's going to give to your patient.
Thank you very much. Is there a question that goes for around 260? And the other that look at the benefits. Actually, it comes to you. There are a number of questions on the management. So there are 3 4 medications that we are mentioning here. So if you could take them together. So what's the role of prednisolone in CKD management? Somebody is saying that is spironolactone contraindicated in CKD. NSAIDs, do you use it in people with CKD? What about those on dialysis? Can you even try using it for those clients? If you can take this one.
Prednisolone has been used for certain. Okay, thank you very much. So in terms of the prednisolone can be used for certain specific conditions in chronic kidney disease. If you have a primary glomerular disease, we usually use prednisolone, and depending on the type of glomerular disease, we have other immunosuppressants we add. We have something we call the rapidly progressive glomerulonephritis. If the kidney function, is rapidly progressing, and we also use prednisolone. Sometimes we use prednisolone in cases that we call an unexplained or undetermined cause of chronic kidney disease. But even in those cases, we should do a biopsy to be able to find the exact cause of that kidney disease. And sometimes as we are awaiting the biopsy, we might give the prednisolone, especially if you don't have a prior knowledge of the patient's baseline kidney function, with the hope that that can reduce the inflammation and help improve the kidney function. So there are specific indication for use of prednisolone in patients with chronic kidney disease. And most of these, in addition, you have to do a biopsy to be able to diagnose and know where to go in terms of the medication, the immunosuppressant, because prednisolone, in as much as it's a very good drug, it has a lot of side effects. And you should know when you are using it, you should know how you are using it, and the duration. Yes, so those usually is in consultation with nephrologists so that we can manage the patients. In terms of the spironolactone, whether it can be used in CKD. Yes, so spironolactone, if we look at the algorithm, spironolactone is a steroidal mineralocorticoid receptor agonist. So in terms of the blood pressure management, we said we usually start on with your ACE and your ARBs first, and you can add on the non-steroidal MRAs. But if a patient has heart failure, spironolactone has added benefits in heart failure with reduced ejection fraction. In those cases, you can give them the steroidal MRAs like spironolactone, or if the patient has refractory hypertension, you can give spironolactone, or hyperaldosteronism, you can give spironolactone. You don't combine the non-steroidal and the steroidal MRAs because the risk of hyperkalemia is very high, and it can also cause kidney injury. Yes, so spironolactone has a role to play, usually as add-on antihypertensive. So if the patient has a heart failure with reduced ejection fraction, hyperaldosteronism, and the rest. In terms of its cardiovascular benefits, it's also there, but the kidney benefit has been proven more in the non-steroidal MRAs compared to the steroidal MRAs like spironolactone. Yes, so NSAIDs can cause kidney disease. They can cause an acute kidney injury on top of the chronic kidney disease. So usually we advise against using NSAIDs in patients with chronic kidney disease, especially in the advanced stages. So we don't usually give NSAIDs in patients with chronic kidney disease, and on dialysis too, we usually don't give NSAIDs in patients on chronic kidney disease, because even the small kidney function that they have left, we want to preserve it as much as possible because of added benefits if the patient is going to have transplants and all that. Yes.
Thank you very much, Abusa. I'm sure all will ask questions around this and you've been answered. Dr. Baba, quitting smoking is very difficult. Very difficult. And we are saying that people, or we think that we should let them reducing, so probably they stop. Another person saying that, yeah, last time the market this morning, a lot of the fruits that have been sold there, they say that they are contaminated with a lot of chemical, whether what they are taking is not contaminated, especially when Akosia is telling us that there are unexplained causes, some of these things. So how can you convince us that as we do the lifestyle, what we are actually taking in is not what? Baba, it's only to you.
Okay, thank you very much. I will want to, being a primary care physician, I can understand how difficult it is to stop some addictive lifestyle behaviors like smoking, alcoholism, and all that. But I can assure the person that there's a multidisciplinary approach to that, where it will be patient-centered to the person to address the particular barriers that is preventing him to stop smoking. So that when we know those issues, visit a health professional who will now help him address what is becoming like a barrier for him to stop smoking, and help him with counseling sessions and also other therapeutic alternatives that will help to break the addiction for him. And there'll be countless occasions where people have successfully stopped smoking. So it's not the end of the world. It's possible and done all the time. There are nicotine replacement therapies, patches, other things to help with the cravings you have when you stop smoking, so that you can actually stop smoking and then protect your kidney health. When we talk about finding out about fruits, vegetables, and how they may be infected with pesticides and other things, the honest truth is that you cannot definitely tell by looking at those foods. It's not written on it that, hey, I have pesticides, I don't have pesticides. But what you can look out for, I think, in your own way, would be some extraordinary features about the fruits. We all know that a finger of banana usually is about a particular size. So you go to a market and you see something that is looking really out of the ordinary, out of shape, or your fruit and vegetable is looking out of proportionally the having vibrant colors than you actually know that this fruit, then you can think about that something has to be done to encourage the fruit or vegetables growth. But occasionally we get some notifications from regulating bodies when they realize that something has been infected. So you may also hear that in the news that, oh, this has been contaminated. So don't take it, all that. So that may be what we do. The definitive way to find out will be a lab analysis to know that this fruit or this vegetable has been infected with pesticides. So basically, that's how we can tell. Stick to the usual things you know at your backyard garden. You know that the color is dark green for contomere. Don't go and pick something that's looking lemon green for contomere because it looks more appealing to you. Thank you very much.
Thank you very much, Baba. Okay. So that you can grow some yourself and you know that there's no chemicals that have been impregnated into. So they are coming back to you. Say that you're talking about ARBs. One, which one of CKD? That's one. Two, in patients who is going to have CKD, stage 3 onwards, should they still go ahead and push these ARBs or ACE inhibitors for this client? Then of hypertension. So somebody has a CKD, you don't give them the cost. So let's say them, and the BPs are well controlled. Should you still add your ARBs or your ACE? So these are 3 things on ARBs and ACE.
So in terms of the ACE and ARBs, there have been a lot of studies on both of them, and both of them have kidney protective effects. Both the ACE and ARBs have both kidney and cardio protective effects. Sometimes it's a bit difficult to say exactly that the ACE inhibitors have more cardioprotective effects compared to the ARBs. Either of them that is available, we wouldn't say that you should only use ACE inhibitors or you should only use ARBs. Sometimes if you start your ACE inhibitor and for a reason a patient develops complication like some angioedema or a chronic cough, you can change from the ACE inhibitor to ARB. So both of them are good, unless one is contraindicated or the other. In terms of the using them for the high blood pressure. So it's not just for the high blood pressure, but also the proteinuria. So if the patient has a normal blood pressure, but with marked proteinuria, we also give them the ACE inhibitors. If a patient's blood pressure is 120/70, but it's having about 300 milligrams per gram of proteinuria, we'll still start with a small dose of an ACE inhibitor to help with the proteinuria. So even if, so far as the patient is not hypotensive and the patient is having proteinuria, you can give the ACE or the ARB for the antiproteinuric effects. In terms of the hypertension, we said that that is the first line antihypertensive for our patients with chronic kidney disease before you add on the other antihypertensives. But if the blood pressures are fine and the patient still has proteinuria or the patient has heart failure, and then you can add the ACE inhibitor or ARB for its added antiproteinuric effect or its added heart failure mortality reduction effect. Yes.
Thank you very much, Baba. Someone says that that's one. And we are talking about timelines, 3 months, 3 months. What if you have a client that only that's quite severe? As you're going to wait for your 3 months to see that this client has CKD. And the third one is saying that if out with a what does it mean? It's no CKD. If you can take this one.
Okay, so I'll start with the last question. If you remember our definition very well, it said that CKD is a structural abnormality or a functional abnormality with EGFR less than 60. So when you have EGFR at 58, it is still less than 60. And as long as you can confirm that had gone on for 3 months, then the patient has CKD. If you look at the glycol heat map I pulled up, you realize that there are instances where your EGFR will be very low, but you don't have proteins in your urine. What that tells you is you still will be at risk. At 58, it will be moderate risk or moderate CKD. And these patients need to be followed up at least once in a year. And also to actively reduce the risk factors and then do some sort of treatment for the patient. So yes, you can have CKD at 58 with normal or no proteins in your urine, and they need to be treated as well. The second question where you need to be sure about the timing, yes, because AKI or acute kidney disease may also have symptoms and signs similar to CKD. The pulmonary edema, all the other things I spoke about, fatigue, because acute kidney injury will also produce those signs. But I think that will characterize or differentiate between them really is the time duration. If you've seen this go on for 2 months, most likely it will be CKD, but for you to definitively diagnose this, you need to wait for 3 months and have 2 tests being positive out of the tests that you have done. The first question was the classification based on age. I'm sorry, the presentation seemed to be more adult focused, but in children, I will make Akosia adult. But in children, the classification still remain the same, stage 1 to stage 5, but their calculation of EGFR is different with a different formula, and that will put them. But at the end of the day, they are still classified as having CKD based on their own risk factors. Most of it will be really congenital abnormalities or more of obstructive uropathy when they have some backflow, and then also the cancers and then nephrotic syndrome.
Okay, so in terms of the classification, so there's especially in the elderly, there's a whole research and debate going on whether if you see an elderly patient with a GFR of 70, whether the patient has CKD or not. So in terms of even the EGFR calculation, as Dr. Damwa said, we have a calculation for children. Usually they use the Schwartz calculator. And then the CKD EPI and the MDRD usually for adults. And then in the elderly, more than 75 years, we have a different calculator. Some example is the full age spectrum calculator that was done for the elderly, because in the elderly, the CKD EPI and the MDRD, they didn't use the elderly population. So in the elderly, that equation might not really be so accurate. In terms of the elderly too, if an elderly patient, an 80-year-old patient has a GFR of 70, no protein in the urine, no blood in the urine, has no comorbid condition, would you say this patient has CKD? So there's a whole debate going on, and some people are of the view that in the elderly who have no comorbid conditions, who have bland urine, who have no symptoms, no structural kidney disease, if the GFR is more than 60, we shouldn't really classify them as having CKD. And that is something that is it's ongoing. So in the elderly, we look at them differently compared to the younger people. Yeah.
Thank you, Akosia. I think that we'll take this last because time, but I think that we need to. So somebody's major concern is that if you diagnose somebody of CKD, can it be the client comes and it's like that you are going to be feedback. Is it fully cured the diagnosis of somebody with CKD? If you are managing somebody with CKD, apart from BP control, what else? I wanted to end with that one so that you can that's one. Things that apart from BP control, sometimes they are lost. I mean, I've controlled BP. What else should I do? Do you have some in Ghana? I know that this question will definitely would come and end with when do you start that one first before the steroid? So the question is that is it possible to begin a non-steroidal MRA in a CKD or DMH?
So in terms of established CKD, we can manage such that the kidney disease might progress at a very, very slow rate. Normally, as you are aging, your kidney function deteriorates with time. So even as you are aging, past 40 years, your GFR goes down by about 1 mil per minute per year. So with time, the GFR will automatically go down slightly. But in terms of completely curing an established CKD, it is manageable, especially in the early stages. If you are able to manage the CKD very well, you can reduce the progression to the barest minimum such that it will progress normally, like with normal aging. As to whether the CKD will completely go away, that might be a bit difficult, but you can manage to reduce the progression to the barest minimum.
So you're being political. Yeah, very political. Okay.
Then in terms of the second question, you were talking about the management so the management, you said
you end up that one, but if you go take whether we can have the flow in Ghana and also the is it possible to begin the non-steroidal CKD or we have always begin steroidal MRA? Then we can end up with the management in terms of apart from the BP, what else you share?
Okay, so the finerenone, I'm not sure whether we have it in Ghana. I mean, now there are a lot of drugs. There are people on those medications. The one I saw was from outside. Most people bring it from outside. But as to whether we have it here in Ghana, I don't know whether pharmacy people, I'm not sure about that. And whether we have that in Ghana, but I would not be surprised if we do. In terms of the MRAs, so with the finerenone, that is a non-steroidal MRA. So usually it is an add-on medication if the patient has type 2 DM, hypertension, and you've given the initial medications and you are still not controlling, you can add on the non-steroidal MRAs. Here in our part of the world, if you have the steroidal MRAs like spironolactone and the patient has hypertension, you are on the medication and the patient you are on the regular medications and the patient's blood pressure is not well controlled, you can add on the non-steroidal MRA. Or if the patient has heart failure or if the patient has hyperaldosteronism, you can add on the non-steroidal MRA for its cardiovascular benefits. If you look at the algorithm though, with the very new algorithm, the steroidal MRAs are higher compared to, I mean, you add that one earlier compared to the non-steroidal MRAs. But in our part of the world, if you don't have the steroidal, I mean, if you don't have the non-steroidal MRAs, and you can give the steroidal MRAs, especially in patients with resistant hypertension, in patients who have heart failure with reduced ejection fraction, and in patients who have hyperaldosteronism.
So just as a brief summary on managing the BP.
Okay. So the management protocols, the first one is the lifestyle modification we spoke about, salt, reducing salt intake, balanced diet, more vegetables, more fruits, adequate hydration, exercising regularly, avoiding tobacco, and also making sure you avoid illicit drug use and nephrotoxin. So the lifestyle modification is there. And then the second arm is to reduce or to slow down the progression of chronic kidney disease. And we spoke about managing the blood pressure with a target systolic blood pressure of less than 120. If the patient has diabetes, you manage the diabetes as well. And then you also look at the complication. If the patient has hyperkalemia, acidosis, anemia, or calcium phosphate, PTH, and CKD mineral bone disease abnormalities, you manage them. And then the cardiovascular part, where you manage the cardiovascular protective arm. If the patient needs lipids, you give them lipids. If aspirin is indicated, you give aspirin as well. And I think I spoke about the various indications for each of them. So these are the various arms we look at in managing the patients, and regular assessment of the patient and counseling of the patient and the caregiver as well is very important.
Thank you very much, Akosia. Now I have my new, so the floor. If there any, I know all your questions have been answered, but let me still ask. Is there any person audience with us? Well, questions, and we appreciate you being here. I want to take this opportunity to appreciate everybody who stayed on with us. On with us throughout, both on our YouTube channel and our Zoom virtual channel. We really appreciate your presence here. Want to appreciate Dr. Baba Damoa and Dr. Akosia Asimene for AstraZeneca for sponsoring us and telling us about this magic drug that is complete. Thank you very much. Just a way of announcement. In 2 days' time, we are here again. We are making sure that in the month of World Family Doctor Day, every problem, every issue at the primary care level, month of May, all your issues at the primary care center is sorted out. We listen and we make sure that we deliver. Sent to me that we should make sure that we deal with, we are dealing with. So in 2 days' time, we are coming here on the update of and diabetes in primary care, updates in the prevention and management of diabetes in primary care. Same time, 3 o'clock. We are closing. Today we've gone just 3 minutes beyond 5:30, and it's just because we love you. We appreciate everybody, and same time in 2 days' time, Thursday. From there, we are moving to Tamale. If you are listening to me and you've not booked your flight, you've not booked your kindly do that. Because we are moving to Tamale for our ATSM, a very good coordinated program that we have for you. On Thursday, we're going to have a stakeholder engagement that is to achieve universal health coverage. Achieve universal health coverage through collaboration. So we are going to have a stakeholder engagement. We're going to have another CPD in the afternoon. Then we're going to have a cocktail. I mean, I know in Accra you don't enjoy cocktails, but yes. So Friday we're going to have a scientific section where we're going to have some discussion on how care at the primary care level. We're going to have NCD program and NIR coming to lead us in the presentations. Then on Saturday, in the evening, we'll be having our general meetings. All family physicians, make sure you are on a meeting. Friday evening. Saturday is a chilling Saturday. We're going to the Mole Park in the Red Cliff. Or we can put you on the bath. In the evening, we're going to have a dinner, award dinner with live band. I mean, the last time that I enjoyed dinner for you on Saturday, and Sunday will be our Thanksgiving service. Every family physician must make sure. Every family physician. No, when you mention something 3 times, then it means that you know something. Thank you very much. I prepare to meet at Tamale. But before then, on Thursday, same time, 3 o'clock, and enjoy yourself. Stay blessed.